I'm Kathy Julian. I'm Associate Dean for Graduate Medical Education, and it is my absolute pleasure to introduce our speaker today. Our speaker is Dr. Denise Connor, who is a professor of clinical medicine and the Gold-Headed Cane Endowed Teaching Chair in Internal Medicine at UCSF. And Dr. Connor has her clinical home in the Faculty Hospital Medicine Division at the San Francisco VA Medical Center. Dr. Connor is a graduate of the UCSF Internal Medicine Residency Program and participated in the Health Equities Academics and Advocacy Training Pathway. She began her career educational path as a chief resident based at the San Francisco VA and later joined the Medicine Residencies Prime Program, where she served as an associate director from 2013 to 2020. Dr. Connor designed and was the inaugural director of a novel capstone diagnostic reasoning course for pre-clerkship medical students at UCSF. She was the first chair of the Academy of Medical Educators Diversity, Equity, and Inclusion Committee, and she is now the director of the School of Medicine's Anti-Oppression Curriculum Initiative. And she is honored to collaborate with faculty, students, staff, and community members to elevate the School of Medicine's emphasis on justice, equity, anti-racism, and anti-oppression across the entire four-year curriculum. So I am really honored that Dr. Connor is going to present for our GME Grand Rounds, and I will turn it over to Dr. Connor. And the only thing I will say before I do that is please feel free to submit questions via the Q&A, and we will pause periodically to answer questions. So thank you, Dr. Connor, for joining us.
Thank you. That's a really kind introduction. I really appreciate it. And I really am grateful to be here with all of you. It's really wonderful to talk to our GME colleagues. So thank you for having me. So I'm going to start by just mentioning some technical things. I have no financial relationships to disclose. And also for anyone who has any accessibility needs, if you want to put those in the chat, Catherine Chadwick, who's one of our lead staff members, is going to be kind of keeping an eye on that, and I'll check in with her at some point in the next little bit to see if anyone has anything that I can do to make this presentation easier to follow along with or better for your needs. So please let us know. I want to start by a Native Lens acknowledgement, and I want to especially appreciate Anne Montgomery, who used to be here at UCSF and unfortunately is no longer here, as well as Tassi Bongiovanni, who worked closely with members of the Association for Ramaytush Ohlone to develop this land acknowledgement. And I'm going to go ahead and read it. We would like to acknowledge the Ramaytush Ohlone people, who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land UCSF sits upon, their home. We're proud to continue the tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And I want to acknowledge that these can feel very performative at times because they're just statements. I've put the Ramaytush Association's website at the bottom of the slide and would encourage people, if you're not familiar with what they do in the Bay Area, all the really wonderful work they're involved in, to take a look and learn more about them and their work. That's one small thing we can do to make that acknowledgement real, is to commit to learning. I also want to take a moment to just acknowledge the context, the global context that we're in right now. I really don't know that I definitely don't have the right words, but I will say that there's just an enormous amount of suffering that we're all witness to for the last 10 weeks or so, and it's very hard as healers to see that. I think, there's people in our community that are hurting. There's obviously people in Israel and Gaza who are deeply hurting and suffering, and I want to acknowledge that suffering. And I want to also say that anyone who needs to step away from this talk should, because I'm going to be talking about specifically the School of Medicine and anti-racism and anti-oppression, but given what's happening in our world, that's going to land on different people in different ways, and I would encourage people to step away, take breaks if you need that. And I also want to remind people of the resources for support that we have on campus. If you need that, or you have a friend or a colleague that you think would really benefit from that, here are some places to go for it on our campus. And I'm also available. If people want to reach out to me, please do. Okay, so I'm going to start with this quote from some colleagues in a recent paper that I really appreciate. In conceptualizing anti-racism as a stance, we understand it not as a task, an event, or an outcome, but as a shared lifelong practice. And I think this is really, really important because at the beginning of the Anti-Oppression Curriculum Initiative, people often said, okay, when does the curriculum start? What will be the start date? And as though it would kind of be finished and we could check that box. And I think in reality, it's an initiative, it's a catalyst for work that has already been happening here at UCSF for a long time. We were trying to take that work and build on it. And we very well know that we are still very early in the process of moving towards anti-oppression. I started anti-racism because we chose to name this initiative the Anti-Oppression Initiative because we wanted to be broader and have a broad sense of the types of oppression that impact people. And I think of anti-racism as fitting within the umbrella of anti-oppression. So I think this quote has been helpful for me as I think about our work. And with that in mind, given sort of the ways that this work is very personal, I think when we think about equity, anti-oppression, and anti-racism, it's important that we position ourselves and talk about how we came to this work. What is the lens that we bring to this work? Because it deeply shapes how we do it. It deeply shapes both what we understand and what we don't understand, and we need to maintain a lot of humility around. So I'll just take this moment to share very briefly one part of my identity that really drew me to this work and that continues to inform it has to do with my racial identity. I'm racialized as a biracial woman. My mother is a white woman, my father a Black man, and I look the way I look. And next to me in this picture, that's a long time ago, but that's my cousin. And he is also biracial with a white mother and a Black father. And he and I look really different in our skin and the color of our skin. And I think growing up very closely together and watching how the world treated him and how the world has treated me was a deep introduction to racism from an early age. And that is how that lens is how I look at this issue. And I think it gives me certain understandings. And it also comes with a lot of humility and a realization of how much I don't understand and how much privilege I have based on how I look. So I want to just acknowledge that. And I also want to say, of course, my racialized identity is just part of who I am. The other thing I think my understanding of this work has to do with socioeconomics, growing up in a relatively poor to working class family, depending on the time of my life, shapes my view, and being around disability throughout my adult life, or my childhood and adult life, also shapes my view of these things. So I think I'm still learning about how that informs my lens, but it certainly does deeply inform my lens. So I come to this with a lot of humility. These are my goals for us today, to kind of talk about the AOCI and what we've been working on, and to really think about what are opportunities to collaborate and align with all of you in GME. I think we're still at a very early point in this work, and I know there's a lot happening in the GME space around equity and anti-racism, anti-oppression, and I hope we can take a sort of a lesson from Dr. Kamara Jones, who I'll talk about later in the talk, but one of her lessons was that we need to have porous walls within our institution, as well as between our institution and our communities. And I think GME and UME are two places that we sometimes have a lot of siloed things happening, but we are so intimately integrated in our work. So how can we break down some of those silos and really think about how to collaborate and move towards the world and the healthcare system we hope to have? So with that in mind, I'm going to start by talking about what the context of the AOCI has been, sort of what the vision and structure is to give people a general sense if you're not as familiar. But I want to just emphasize that UCSF has three overlapping missions, right? There's clinical care, education, and research, and they're very intertwined. Education is how I and the AOCI are trying to improve anti-oppression and equity, but we actually need to do that in concert with these other parts of our mission if we're going to be successful. So I want to acknowledge that this is like one little part, and then if you think about education writ large, we have many health professions education schools here at UCSF, and the School of Medicine is one part of that. So much of this work to be successful or effective in moving in the direction we want to move has to do with thinking about how do we work together and align across these different mission areas. The next picture, just a content sort of advisory that it's from the White Coats for Black Lives die-in from 2014. So I'm going to show that picture now. So this is from 2014. I think it's really, really important in any equity, anti-racism, anti-oppression work to acknowledge our roots and think about who the ancestors are for the work. And this is just one moment in time. I'll talk in a minute about where this is situated, but 2014 was a really important moment in the School of Medicine because student activists in White Coats for Black Lives organized this die-in. And at the time, it was about Michael Brown and Eric Garner's deaths. And I think it really led to a sea change in how our institution thought about healthcare's role when it came to anti-racism, and really propelled us into the Differences Matter 1.0 work that then really paved the path for us in the AOCI to start our work eventually. I think it's really sobering to show this slide because it's from 2014, and since the deaths of Michael Brown and Eric Garner, you can think of all of the people who have been killed since then and how much we haven't really seen the progress we had hoped we would. I think it's a way to stay connected with how much work we still have to do. And then thinking about the broader anti-oppression, anti-racism work at UCSF, of which that was just one event. Catherine actually and another one of our lead staff, Tamara, put together this living history to try to begin to look at what are all of the different groups that have been with us over the years that have really gotten us to the place we're at now, where we can say things like racism and anti-racism, which were not words that people were saying when I was in residency. That actually is a change, and a change for the good. So just wanting to acknowledge that we are just one moment in time, and there's all of these other folks who came before us, and people who are doing this work in parallel, including, I'm sure, many of you. This is a living history. We don't think it's complete. And so if you see something that's missing and really needs to be added so we can have a better, fuller picture of our community and its work, please let us know. I'll make sure to include our contact info at the end. And so with that kind of context in mind, I'm going to very quickly talk about what the AOCI is for people who are less familiar. So it's really a 3-year process. We're at year 2.5 now of evaluation, reflection, and curricular adaptation, trying to look at the entire 4-year School of Medicine curriculum and moving it towards anti-oppression. We are trying to do this work in partnership and collaboration, and actually that's the only way you can really do this work. So we have a whole team of students, faculty, and staff members, and invited experts who are working with our curricular leaders to both think about what we teach and how we teach, and to move that towards anti-oppression. And then secondly, we are trying to recognize that the curriculum is just one part of medical education. And if we're going to see progress, we actually need to look at all the parts. So we are partnering with the leaders of all of these parts of the education enterprise. So assessment, student support, faculty development, which I could underscore and bold, which is really, really important, technology and evaluation. And we're trying to make sure that we are all talking often and that we're aligning what we're doing in the curriculum with what's happening in these other parts of medical education. Just as important, I think, is what isn't the AOCI. And I kind of hinted at the beginning, it's not a finished product. We're not there, and we have a lot of work to do. It's also not the end. So the School of Medicine is very committed to this work and understands it as longitudinal, and I would say probably generational work is what we're talking about. So this is a catalyst for that work. And we rely on collaboration. So we are embedded in this anti-oppression charter that the School of Medicine has. And then there's all these UCSF level groups, especially Office of Diversity and Outreach, the Center for Community Engagement, Differences Matter within the School of Medicine, and many, many other people who are also doing this work. And what we're trying to be very careful about is working together and not letting anybody sort of have to start from scratch, making sure we're building on each other's work, making sure we're learning from each other and the different contexts that we're in. And I think I've mostly talked about this, but just what is our goal, I think, is important to stay. And I think there's 3 buckets. The content, what we teach and how we teach it, I spoke about. The other part is thinking about our environment, our educational environment, and how we can shape that towards the kind of anti-racism, anti-oppressive approaches we'd like to see in healthcare. And then ultimately how to help our medical students to partner with the people that are coming to seek care and with communities to continue this work in their careers in the future. And this is just a visual depiction to give you a sense of like some of the ways that we're trying to do this work. You'll see the student collaborative is in the middle at the bottom. And I think centering students is critical in this work, and recognizing how much students have been leaders in this work, pointing to the need for it, teaching us many times about what is needed. And so having those students in our collaborative, we meet with them twice a month, and they give us a lot of input as well as new ideas for directions we should take the work, has been very important. We have a core group of faculty and staff that are working together. And then the other thing I'll just highlight in the 3 boxes at the top, it says, the middle one says invited experts. I would say that's an area where we are making some headway, and I feel proud, but also we have a lot of room to grow. And the idea here is I talked about Dr. Jones's lesson about silos and about porous walls. And one of those walls is between the School of Medicine and the other health profession schools. And another is between UCSF and our community. And so we have tried to invite experts from other health profession schools. We've tried to invite experts from outside of UCSF to teach us, because we're actually quite new to this work. And there are community organizers, there's people who have dedicated their careers to equity and anti-racism research. There's so many people that we can learn from, and we're trying to be humble and keep that in mind as we do the work. So that's something I hope to grow in the years ahead. And then this is just a bunch of pictures to say I'm here today, but there are so many people on our team that are doing this work every day. I pictured them here. And the one thing I want to just say about this, and I think anyone who does this kind of work will tell you, that this is hard work. It's very personally and professionally hard in ways that are different from other things we do in healthcare. And so what I have really benefited from is this community of thought partners, as well as just support to do the work. And I think if there was one lesson I would want to tell someone who is embarking on this work, is you really need to have that community around you to be sustained and to be able to keep doing it. And these are the people who have taught me and continue to teach me so much, and who are in there doing this work with their partners every day. So huge thank you to all the staff and the faculty and the students that are on this slide. Okay, so that's my kind of just giving you a general sense of what the AOCI is. I'm going to move on now to some bigger picture ideas. So for the last 2.5 years, we've really benefited from hearing from so many different people what's important in this work. And a common question is like, what does it mean? I'll say we're bringing an anti-oppressive lens to the curriculum. People will say, well, that sounds good, but I don't actually know what you mean when you say that. So these principles are things that rose to the surface as we did this work, as we learned from more people about what it means to bring an anti-oppressive lens. I'm going to try to share that with the idea that if we can all think about how these principles either already exist in our contexts, or how we could embody them in our processes and in our way of showing up in our roles in our different spaces in the university, I really believe that could help us to push through the resistance that we always feel when we do anti-oppression work, and that could also help us to be on the same page about what does it mean to bring an anti-oppressive lens. In some ways, this builds on sort of an idea like the pride values. So many people have heard of the UCSF pride values as something we can all understand when we say, how are we showing up today in our different contexts? I put a star because I think there's more and more discussion about some of the unintended consequences of the concept of professionalism, which are certainly not what the intention was here, but trying to think about how do we bring an equity anti-racism lens to professionalism is really important. But these values are a starting point. And I think about these next set as sort of how do we build that out, and if we're going to talk about anti-oppression. So there's 4 buckets. I'm going to start by talking in a very broad way, and then I'm going to try to bring this to life with an example. So community collaboration and care. the idea there, and I would say we've learned a lot from our colleagues in the Restorative Justice Office about this one, the idea that, number one, we have to be accountable to our community. And we really need to think about collaboration instead of trying to solve a problem, up in the leadership zone and not really listening and hearing how to solve a problem, but doing it together. And then centering the needs of the people who have been most impacted by discrimination and by inequity as we do that work. The next bucket is truth and transparency. And that has to do with a lesson from Dr. Jones, which is the first step in anti-racism is naming racism. Every time you're in a meeting, every time you're in a space, if you are seeing racism show up in the processes or the systems, we have to first name it before we can do anything about it. And I think in the context of the AOCI, that means we have to name the way that medical education in general and UCSF in specific, as a part of that, has been complicit with racist and oppressive ways of doing things, and kind of resist this ahistorical stance that Dr. Jones would say. We have to acknowledge the history and what role we've played in order to move forward. And I think if we want to be trustworthy, that's a really important step. And then acknowledge where we are in the process, which is early. The next bucket is cultural humility and inclusive listening. So I think we've moved, when I was in medical school, we talked a lot about cultural competency models. I think we've moved beyond those, and they probably were an important step in our understanding. But I think it's nice to be able to say that model had some unintended consequences around viewing people as a monolith, kind of understanding based some common things and thinking that we understood everyone around us by learning some rules. And instead recognizing that we'll never fully understand, that people are intersectional, that there is no one way that a community does things or thinks about things. So that means we have to listen to a lot of people in a really open way. And the last one is active resistance. So when I think about, people have often asked, why can't we just say equity? Why do we have to say anti-racism, anti-oppression? And I think the answer to that is many. Partly is truth and transparency, which I just talked about, but it's also about action. So when I hear anti-racism, anti-oppression, I imagine dismantling systems that are unjust. And in this realm, I imagine identifying the tenets of white supremacy culture that show up in how we do our work here at UCSF, and trying to work against that in a really, real way. So working through and with resistance, I guess you could say. So it's a little heady, I think, to talk about it at that level. So speaking of community collaborators, I have been lucky to have frequent meetings with a community member named Sam Dennison, who's done a lot for UCSF over the years. And they have really been a thought partner for me. And a suggestion Sam gave me was, why don't you use one of Dr. Jones' allegories to explain principles, because they're a little hard to understand. So for folks who were able to hear any of Dr. Jones's talks when she was here, one of her talks is about this restaurant image to understand racism. I'm going to, in a much less eloquent way, describe that allegory and then talk about how those four areas of principles can kind of fit into Dr. Jones's allegory for racism. So her story was based on a true story. I believe that she was in medical school and was studying late with some friends, and they got really hungry, and they all went out to look for food in town, and everything was closed, and it was very cold outside, and they were very hungry, and they finally came to a restaurant that had the lights on inside. Everyone was eating, looking like they were having a good time and being warm, and they were going to walk in, but then when they saw the door, the closed sign was facing Dr. Jones and her friends. And she talks about that as an aha moment where she recognized the people inside the restaurant, they were seeing an open sign, and they might have wondered, why are the people outside not coming in? But the people outside the restaurant were clearly getting the signal that they were not welcome, and that's how structural and systemic racism sometimes operates. So if we think about that story, and then we think about those principles I shared, when you think about community and collaboration and care, that means, number one, there have been people outside the restaurant for a long time with their needs being unmet. So the people inside the restaurant can't figure out what to do about that. Actually, we need to talk and invite the people outside the restaurant in and understand together how to collaboratively work on this problem. Because if you've been inside the restaurant for a long time, you probably don't have the information you need to solve that problem. The other thing I think is important is all of us, myself included, there's times in our lives, maybe there's hours in the day, there's hats we wear where we are invited in the restaurant, and then there's other times when we're not. So our community is not a monolith either. And actually, many of us have experiences of being inside and outside. So recognizing how complex and nuanced it is to be a person and how all of our intersectional identities may exclude us or include us, and thinking about that as we try to work on this problem together. The next bucket was truth and transparency. So people who have been outside the restaurant for a long time are very aware of that. And so we need to be honest about that. What has it been like to try to come to UCSF to seek care for the last many years? What has that been like? Let's be honest about the ways that it's been exclusionary, honest about times where people have experienced discrimination, and that transparency hopefully is a step towards rebuilding some trustworthiness that we currently may not have. Cultural humility and radically inclusive listening, again, kind of comes back to this idea of we don't have the answers if we've been sitting inside this restaurant. We need to be humble and talk to all the different people who have different stories and who have experienced that closed sign in different ways. And then the last thing, active resistance. We actually need to work together to dismantle a sign like that. We actually have to do action to tear down that sign in whatever way makes the most sense, and build new structures for equity. So I think hopefully that'll give you a general sense of what I mean. If you think about a context or a system or a process, you could kind of imagine those 4 categories and think about what would it mean to bring that to this problem. And I would really love to kind of think more with others about how and whether those ideas resonate and how they might show up in your context. And just a word, I'm guessing, given who I imagine is here today, that most people have heard about white supremacy culture characteristics. We'll make sure that this is included in the slides, but this paper by Tema Okun, and then also the artwork here, describes some of the characteristics of white supremacy culture, which there are so many overlaps with healthcare and with medical education. So when we think about resistance, we really do have to think about what are those tenets and how is that culture impacting how we do things in medical education, and how do we work against that? It's a little hard to read this. I'll just name some of the key ones are perfectionism, urgency, defensiveness, quantity over quality, worship of the written word, one right way, paternalism, either or thinking, power hoarding, fear of open conflict, and individualism. I'm the only one. Progress is bigger, objectivity, and right to comfort. So I think those are really, they show up in my work a lot. And I think the first step, just like Dr. Jones would say, is naming that when we see it, and then thinking about what's another way we might approach this problem? How might we do this in a different way? So out of those principles, we can think about what are some processes in our education spaces that could align with those principles. So I'm going to briefly talk about anti-oppression and pedagogy principles. And then after this, I've promised to get more specific about what we've actually been doing and how we've been trying to bring these ideas to our work. So the first is anti-oppression pedagogy. So Paulo Freire and many intellectual descendants, have thought a lot about this for a long time. And it's actually nice to see that some of these ideas, I think, already show up in how we educate, but there's still a lot of room to go. So the first idea here is moving from a banking model of education to problem posing. So a banking model is thinking of learners as an empty vessel that we pour information into. Problem posing is recognizing that learners come with expertise, with a cultural, historical, individual set of identities, and actually should be interacting in a very real way with the information they're learning, and being part of creating and understanding that knowledge in a new light based on the expertise that they're bringing. So it's a much more dialectical, dialogue-based way of thinking about learning that doesn't involve an expert pouring information into a novice. In that same way, we think about learners as partners, as co-creators, learners as having agency and having a very reasonable right to have an opinion about how they should learn or what they should learn. Similarly, we have embedded norms in our educational system that has been there for many years. So what's considered normal and what's pathologized is something that we really need to focus on dismantling and acknowledging when we see it. So a white cisgender heterosexual person with no disabilities from a colonial power who believes in objectivity, et cetera, you could keep going. That's the norm, right? And so how do we resist and work against that norm and recognize that that's a false norm? And then how do we use critical lenses to encourage people to really analyze and think about what we're talking about, what knowledge we currently have, and what are the problems with the knowledge as it's been produced and created so far. Another really, I think the next two will actually in many ways overlap with what I just shared, but trauma-informed medical education, which is an outgrowth of trauma-informed care. Many of you may practice trauma-informed care principles in your clinical practice. And there are folks writing more recently about how can we take some of the tenets of trauma-informed care and bring them to medical education. And there's some overlaps with what I just shared, and there are also some new ideas. So some of the things I'll emphasize are to learn, there has to be psychological safety. Some of the things we talked about, there has to be trustworthiness and transparency of what the learning process is like. And there has to be an ability to be a part of the process through empowerment. We have to focus and attend to the well-being and the strengths of learners, and that we I recognize the ways people's identities impact and shape their learning. And I think the other really important thing about trauma-informed medical education is similar to trauma-informed care, to recognize that most people, learners, physicians, staff, community members, have experiences with trauma. Trauma is actually almost a norm. So we should come to education with that in mind and design our curriculum and how we deliver it and our learning environment with the realization that many people have experienced trauma, whether that's historical trauma, trauma related to racism and other forms of oppression, or many other kinds of trauma that should shape how we think about learning and teaching. And then restorative principles are very linked to what I also just shared, but kind of thinking about how can we be community-centered when we're communicating and when we experience conflict and harm in our culture and of education. And I think what I am beginning to think about is that harm, we want to minimize harm, but we actually can't get rid of harm. So trauma-informed medical education should also recognize that we experience trauma before we come to medical education, but also being a clinician comes with a ton of vicarious trauma, as you are all very well aware. And so we actually, as learners and as clinicians, and we should build our systems with that understanding in mind. It shouldn't come as a surprise if we're facing the reality of racism impacting our patient, how hard that's going to be and how that's going to have a differential impact on people based on their own personal and communal histories. Okay, so now I'm going to move on to some specific work we've been to try to, I don't really like the term best practices, but to try to name what are some of our shared understandings that we want to make sure infuse our curriculum. Excuse me. We had a few task forces, and we have one going on right now to help us think about how we talk about social identities in the classroom. Catherine will put in the chat some links to this if you want to take a closer look. I want to first emphasize that this is really about the classroom. And as you'll see as I get to later slides, one of my hopes is to work with GME and Differences Matter and other partners to think about how do we do this in the clinical setting. There are definitely people already thinking about that. So that's what these recs are really. Many students, faculty, staff, and some community members who contributed to them. And I just want to shout out the people at the bottom who really helped lead these task forces on race, ethnicity, sex, gender, and sexuality. So some core principles that I think we probably could all agree on across all of our contexts are that in everything we do when we talk about identity, we should really be resisting that history of pathologizing people based on their identity. That should be a core understanding principle. That we should be supporting and welcoming inclusivity and seeing the power of that. That we should recognize the way oppression impacts health and illness. and that we should uplift the strengths of people and communities that have faced oppression and are still here, right? There are many things that we can learn from people who are experiencing oppression in their day-to-day lives. So trying to get more specific when we think about social identities, we really, really wanted to be clear with our educator community that race and ethnicity are social identities. They're not the same as biology or ancestry or genetics, and that we should be consistent when we talk about that. That gender is non-binary and that it is also a social identity and is not the same thing as sex characteristics, biology, anatomy, that those are different things. And that, importantly, identities should never be pathologized. They are not risk factors for illness. So it's not race that's a risk factor for illness or gender. It's experiences often with oppression that relate to those identities. So we should name and address the upstream causes as opposed to pathologizing the identity itself. So those are some of the core principles that I think I'd hope that there's sort of wide agreement in our classroom and in our clinical spaces around. How to actualize that is going to be different depending on the context. I just have a couple of quotes. I'll just let people read that for a minute. So in terms of specifics in the classroom, this means that we ask people, teachers, when they're writing cases or writing about patients or people seeking care, that self-identified race and ethnicity can be put into the social history. There's an example there of how it might read in a paper case. That social and structural determinants of health can also be shared in the social history, but that in brief vignettes, like an exam question, that we should not be using race and ethnicity. And that's because of the next bullet, because if we do, there's a way in which it seems like we're prompting people for a specific diagnosis based on identity, which we really want to avoid doing. And for the same reason, and also to try to reduce the impact of implicit bias on patients or on people seeking care, that we may not want to use race and ethnicity in the initial identification or one-liner for a patient, that would come later. I'm going to move on to gender, and I'm going to share these two quotes if people want to take a look at them, and then I'll move on to the specifics. So with these kind of ideas in mind for sex and gender, we are recommending that our teachers, when they're writing paper cases, that we introduce people with name and their pronouns, that we only really need to give sex characteristics in like a problem representation or one-liner when it's very relevant to the chief concern. And similarly in a vignette, only when it's relevant. So these two examples here, GD is a 62-year-old man, he, him with ovaries who presents for pelvic pain, and ovaries are important because the person's here with pelvic pain, versus DL is a 34-year-old woman, she, they, theirs in clinic today for a COVID booster. Their sex characteristics are really not relevant to their COVID booster. And then the other recommendation we had that I think would be relevant to this group is that when we're talking about whole groups of people, when we're talking about pregnant people, use gender neutral language. Certainly when we're talking about an individual person, they have a gender, they have pronouns, that's very appropriate to use. But if we're talking about a whole group, that we try to be inclusive of everyone. And then the last thing in this realm is around framing research findings. So I think the first point is that there are many misunderstandings as well as just harmful beliefs that are transmitted through how research is reported and even done. And that part of our role as teachers is to point that out when we see it happening. So point out when race and ethnicity is being used inappropriately as a proxy for biology or for structural racism. Similarly, point out when sex and gender are being inappropriately conflated in a paper, or when they're being described using just a false binary and not including the full spectrum of gender or sex diversity. And similarly, it's being used as a proxy for something else. So as we continue this work, the next steps for us, we have 2 student fellows this year who are wonderful and are working on deepening those initial set of recommendations for our classrooms, Ali and Jessica. And then the next bucket is we have a disability and working against ableism task force that will hopefully be giving us a similar set of recommendations when it comes to disability. expecting some recs in 2024 on that. And we have a group right now that's just in the planning stages that's going to be talking about size inclusivity and how can we think and talk differently about weight in the curriculum. And in the future, I really would love if there's anyone in the room who wants to think more about this. I'm trying to think about how would we collaborate? How would we partner? Who would we partner with to think about these same questions in our clinical spaces? I'm going to move on to our curriculum review tool. So action is important. Words are important, but so is action. And so we have similarly, when we started off, I was saying people were like, well, what does it mean to bring an anti-oppressive lens to this session? So we worked with a lot of students and faculty and staff and some community members actually as well to think about that question. And to provide some scaffolding for curricular leaders as they think about how do I look at this session with this lens. So this tool is trying to get very specific about questions that could be asked and discussed that could prompt both reflection and learning and also adaptation of curricular design and curricular sessions. I think Catherine's going to put a link to the tool in the chat if people are interested. And I think the important thing about a tool like this is one, it's really scaffolding. So it's not a box. It's not meant to give people answers. It's really meant to prompt these deeper discussions and then to prompt change. And then the second point is trying to be trauma informed. One of the tenets of that is that learners have a real big role in how we do and adjust our processes. So that means this is tools not done. This is, I think, is our we've had many iterations of it. I think this is officially iteration 2, but I think there's been more like 12, where we keep adding to it, keep adjusting it based on more input that we're getting. And the other thing we've tried to do is we have worked with our evaluations team to really develop new systems for anti-oppression feedback. So we're trying to make sure that what we learn from students through those new systems is getting into tools like this, is getting also into the recommendations that we have about social identity so that we're continuing to learn and we're continuing to iterate and adjust these different tools. Anti-oppression and equity pedagogy is much more difficult than content. So it's easier to fix a slide with some of the issues I just talked about. How do we not pathologize race? That's really concrete and it's easy for people to get their head around. So that's where we started. But we are trying to think about, okay, but how do we change the way we teach? So I'll give a couple of examples of what we're working on in that realm. The first is, so when we think about psychological safety and learning, one of the ways that that can go wrong is when you have learners with many different levels of expertise learning about a subject that's deeply personal together. And so there has been some harm that's happened in those settings for many reasons, but one of them has to do with that ways that some people are at the very beginning of their learning and some people are like experts. So one of our student fellows, Ali Gomez, is working on this differentiated learning approach. We're going to be piloting this spring where we are asking students to self-select into their level of expertise around LGBTQIA health. And then people will have a small group experience based on where they started from that will hopefully meet their needs, their learning needs, and help everybody get to the next level in their learning. Another really important thing is how do facilitators of some of the small group discussions actually get the kind of training that they would need to be able to be trauma informed, to be able to bring restorative principles to their facilitation, to really elevate belonging, to facilitate when harm happens. So I'm really excited about this. This has been a long time in the process of trying to develop this, but we are very close to partnering with a community group who's going to help really develop a novel facilitator training specifically for facilitators who are trying to facilitate about anti-oppression, anti-racism content, and then having a train the trainer model where they'll also be training those folks who go through that first pilot to then train others. So I'm hoping we'll be able to expand our capacity both in the School of Medicine and hopefully beyond in the future for how to have the skills that people need to be able to really facilitate these discussions. And then the last thing I'll say before taking some time for questions, I think, is community collaboration. So this is definitely a work in progress. I feel like we've made some strides, but there's still a lot we'd like to do. So the first is we have had community experts on some of our task force and working groups. And the most recent one, the Disability Task Force, is the one that I think that's done the best job of this, partly because of the learning we've had in the first 2 task forces. So we actually had one of the people who is a community disability justice expert is in that group, and also just piloted a community-led training for members of the task force as well as other members of our community. So hoping to do more of that. We have tried to increase the amount of times that we have experts from the community coming in to do teaching, to really recast what it means to have expertise. And one of the barriers institutionally that we've been working on is how to move from gift cards to actually honorarium for that kind of work. And then lastly is just relationship building. And we've been working on that in many different ways. On the horizon, just so people have a sense of some of the things we're going to be doing next, thinking about how do we transition from the classroom to the clerkships? How do we do that knowing that anti-oppression looks different in those places? We have 2 informal groups that are working on looking at our structural competency and trauma-informed clinical care curricula and how to make some headway there. We're collaborating with the CFE a lot on how to align what we're learning with what they're doing for faculty development. And then I think I'll give that. And then the last thing is, what do we do next? So the 3 years is almost up. We're working with our team, with a lot of people, to think about how we pass the baton, what comes after us. So I hope to have more to share about that in the future. A lot of ways to stay connected with us, to reach out. And I'll make sure that we share slides with the leaders. And I think, just in the interest of time, I wonder if we have time to talk about a few questions or comments. So I'll pause there.
Yeah, I don't see questions, but I have a question. Maybe I'll start with that. Denise, I'd love to hear, as you think about the next stage of the AOCI work, and you were kind of talking about moving into the clinical spaces, issues that come up often include the hidden curriculum that is in the clinical spaces. And I don't know if you want to comment a little bit about that, about how you're thinking about that, or, how do you think about addressing that?
Yeah, that's such a good question, and it's so hard. I am lucky to work with Denise Davis, Dr. Denise Davis, who leads our student support arm in collaboration with the SET team. And I really think it's student support and learner support is one really important place, because we're not going to change. There are hidden curriculum. I think often we were talking about the negative stuff. There are some positive things in the hidden curriculum, like caring about your patient, things that come out. But I think when we're talking about hidden curriculum here, we're probably talking about the bias that shows up and the ways that oppression shows up. And I think I want to say that we are one day going to get there, where every faculty member, every staff member, every patient, every person seeking care has some shared common understanding of what it means to be equitable, what it means to be anti-racist, anti-oppressive, but that's going to take a generation or more. So in the meantime, I think we need to network while we also think about how do we support learners knowing that this world is the way it is. And that's part of that task force, to think about that transition from the classroom to the clerkships. I think I'm hoping, excuse me, that one of the recommendations will be, what's a relational way to support people who are going through this and seeing all the painful things that we see in the clinical context. So I think that's one thing that we need to be thinking about. And then the other is working with Sandrine and the CFE on faculty development in the meantime, and how to penetrate. I think usually the people who come to those events are already very well intentioned. And how do we get the people who don't usually come to those events to engage? What does that look like from the clinical department side to encourage and to value this kind of learning?
Thank you for that. Well, I know we are at time, but I know you have also graciously offered to stay just a minute or two over if people do have questions they want to submit. I want to thank you for joining us today. I also actually want to thank our GME team, Dee Martinez and Cindy Gayton Morrison, for helping us organize with this. And I know we have one question that's come in, so we'll pose that to you in a minute. And before folks leave, I know that Dee was going to put also a survey into the chat. Catherine, would you like to just share the question that came in and any discussion?
Sure. Yeah, really thoughtful question. Thank you from Jen Lee. They said, "Hi, thank you so much for your wonderful talk. I'm hoping to hear more about the work being done educating educators on facilitation on anti-oppression topics. Specifically, what are the educational strategies that can help support faculty in gaining skill and comfort in facilitating discussion with trainees?"
Yeah, that's such a good question. And there's so much to say here. I think one of the things that we're hoping to talk about is how do you create opportunities for empowerment and choice? So one of the things that often happens in like a small group session is here's a prompt, and now we're going to go around the room and everyone's going to answer that prompt. That's not very trauma informed, especially if the prompt could be triggering for somebody or could bring up prior experiences. So how do we have offerings? Like here's low, medium, and high level of engagement with this content. What's going to work for you right now? When can you step away? How do you move away? How do you decide I need to learn about this in a different way? So content advisories, I think is a better word than trigger warnings, because we can't make content not upsetting, right? If we're talking about racism, that's upsetting. But how do we give students and learners the empowerment to decide, I am not going to physically in the room with all of my colleagues during this talk. I'm going to listen to it at home where I have a supportive person nearby where I can talk about it later, or I'm going to schedule a therapy session around this time because I know this block is going to have a lot of difficult content to think about. So that's one strategy that's more of a structural strategy. I think in the moment, trying to help facilitators think about how do you bring that same empowerment and choice into discussions is like an example of how to be trauma informed. And I'm thinking that this training that we're going to develop, I will definitely be talking to Dr. Julian about maybe having some GME folks join us for the training potentially to see what comes out of that and what might apply, what could apply to the GME spaces, because I think the group that we're going to be working with has a lot of really thoughtful ways of thinking about being trauma informed in our facilitation.
I love that. Well, thank you. I really appreciate you spending this time with us. Thank you all for joining, and we wish you all well.
Yeah, thank you. Please reach out to me if people have any questions. It's Connor at ucsf.edu.
Awesome. Thank you.